So good afternoon. Today, Lieutenant Governor Polito and I are pleased to be joined by Secretary Sutters, as usual, and Michael Curry, who's the head of the League of Community Health Centers here in the Commonwealth, to talk about an update on the vaccine program here in Massachusetts. But first, I do want to give a quick update on the COVID-19 numbers. Yesterday, the Department of Public Health reported 3,750 new cases of COVID-19. That was on a base of 327 new tests, and over 12.9 million tests in total have been reported so far in Massachusetts. 1,946 individuals are in the hospital being treated for COVID, and 409 are in the ICU. Obviously, this is a continuation of a positive trend we talked about a week ago. The 7-day average of confirmed cases is just below 4,000, which is the lowest value we've seen since December 4th during the post-Thanksgiving surge. The 7-day positive test rate is below 5% at 4.85% for the first time since the end of November. And our hospital census is below 2,000 COVID patients, coming in at 1,946, which is the lowest number we've seen since the 19th of December. Obviously, we still have a lot to do, and we absolutely need to stay vigilant with respect to COVID. But after the surge of the holiday, and thanks to the hard work of everybody here in the Commonwealth, the data seems to be moving in the right direction. Due to that positive momentum, we announced last week that we were lifting some of the restrictions that were associated with the surge in the first place, and we hope to be able to continue that reopening process. But obviously, we need to continue to see positive trends to make that happen. Now, after months of battling this horrific virus, the vaccine, as we all know, is finally here, and with that, a path to return to normal. To prepare for the task of quickly vaccinating at least 85% of our residents, that's 4 million eligible residents, and depending upon which vaccines get approved, we would be double dosing many of those people. We created a vaccine advisory board to guide us on this. It's comprised of medical professionals, community leaders, and other local officials, and came up with a phasing plan. That plan protects the healthcare system, our most vulnerable residents, and addresses equity, particularly for communities of color that had just been disproportionately impacted by COVID-19. And on December 14th, we vaccinated our first resident. Since then, we've made progress, and now everyone in phase 1 is eligible to be vaccinated. That includes all healthcare workers, all first responders, all long-term care residents and staff, and residents and staff of different congregate care facilities, such as those that serve the homeless, people with developmental disabilities, and people with mental health issues. As of this past Saturday, 448,892 doses, that's first and second for some people, of vaccine have been administered for phase 1. Lieutenant Governor Polito will talk more about that in a minute. Today, we're also announcing the next expansion of vaccination sites across every section of the Commonwealth. At the end of this week, there will be 103 publicly available vaccine sites in Massachusetts. Between these sites and other vaccine clinics for places like long-term care facilities, we'll have capacity to administer 242,000 vaccinations per week. And by mid-February, we plan to have 165 publicly available vaccination sites with the capacity to administer 305,000 vaccines per week. Two important things to note here. First, the capacity to vaccinate is not the same as shots administered. Capacity is what we plan to have the sites, staff, and logistics in place to do. And that would represent 242,000 vaccines next week and 305,000 vaccines the week of February 15th. But those results will depend on several variables, including the availability of doses from the federal government. Second, we're setting up the capacity to administer far more doses than we are currently receiving or projecting to receive from the feds. What this means is if we continue to get the same number of doses we're getting now, we may end up with some empty sites and some empty seats and empty appointments at some of our sites. But I think it's better to overplan at this point in the process and hope that the feds can get there than to underprepare and have them be there when we need to be there. Mass.gov/COVID vaccine has details on who's eligible and has a map of all the available sites that are open and sites that will soon come online. The Command Center will keep updating this map on a regular basis. The website's where everybody should go for information on when they can get a vaccine and where they can get it. The map allows those who are eligible to make appointments at a site that's convenient to them. Vaccination sites are established in every region to provide maximum efficiency, geographic spread, and equity for our residents, and our goal is to keep building capacity, but we can only move as fast as the federal government ships vaccines to the Commonwealth. Right now, we plan to set up 7 mass vaccination sites, which we would describe as mega capacity and efficient. In addition to Gillette Stadium in Foxborough and Fenway Park, sites will open in Springfield, Danvers, and Roxbury. The Springfield site is opening on the 29th of January at the Eastfield Mall. The Danvers site is opening on February 3rd at the Doubletree Hilton Hotel. And in collaboration with the City of Boston, the Reggie Lewis Center will open the first week of February. We'll have more details on this and 2 additional mass vaccination sites in the near future. These sites will begin vaccinating around 500 people per day, and some sites will ramp up to as many as 5,000 per day pretty quickly, with a total weekly capacity of 76,000 per week by the middle of February. Eligible residents in Phase 1 will be able to schedule appointments online for the Fenway, Springfield, and Danvers sites beginning on Wednesday, and appointments should be booked online through the map on the website I mentioned earlier. In addition to these large-scale sites, our administration is establishing other public vaccination sites at a variety of different locations in every region of the Commonwealth and is partnering with many communities that will operate a local clinic to serve their residents. Public vaccination sites listed on the map include places like pharmacies, community clinics, and other providers. These are facilities and organizations that have experience administering vaccines efficiently and safely. Some of these sites are more convenient for harder to reach populations and are located in communities with extremely high rates of transmission. They're marked on the vaccine map as public vaccine sites and restricted vaccine sites. This week alone, we're opening 57 more of these sites. This includes 43 new pharmacy and retail locations like the Big Y, Wegmans, Price Chopper, Hannaford, Stop and Shop, and CVS Health. By the 15th of February, we expect to have 71 retail pharmacy sites open. And as I mentioned, these sites are established to create more equitable access to all communities. Some of the sites are restricted because they're smaller scale operations, operated in many cases by the community and limited to residents from certain communities, cities and towns, or dedicated to certain workers like first responders. They're marked in yellow on the map. If you have questions about when you're eligible to receive vaccine and what sites are available to you, please visit the website and check out the vaccine map for details. Keep in mind that we're going to continue to add to this map as we get more vaccine from the federal government, so everyone should feel free to check back for more sites when they become eligible. Our goal remains the same, to provide our healthcare system with the support that they need to protect our most vulnerable residents and to ensure an equitable distribution of the vaccine to all residents. Today we're announcing updates for the Phase 2 priority groups. Phase 2 vaccines will begin for the first priority group, that's everyone over the age of 75, starting on February 1st. Consistent with CDC guidance, We're also moving residents age 65 and older ahead in the order. This group will start getting vaccines after residents age 75 and older. That's a lot of information, so to recap this a bit, Phase 2 will now go as follows. Adults that are age 75 and older, adults that are age 65 and older, and individuals with 2 or more comorbidities. Early education and K-12 workers, transit utility, food and agriculture, sanitation, public works, and public health workers, and then individuals with 1 comorbidity. Again, beginning on February 1st, adults 75 and over will be eligible to get vaccinated. Residents aged 75 and older will be able to make their appointments online beginning Wednesday through sites on our vaccination map. All this information is available at mass.gov COVID vaccine. To close, I want to run through how residents should approach this process. Visit mass.gov/COVID vaccine and check which group you fall into. If you have a serious medical condition such as asthma or you aren't sure if that changes your eligibility, you should reach out to and contact your doctor. When the state announces that your priority group is eligible, visit mass.gov/COVID vaccine and find an available location near you, and by using that map, click on that vaccine site convenient to you to schedule an appointment online. We're committed to making that process as efficient and as equitable as possible. We all know that COVID-19 has been an incredible burden to every resident over the course of the past 10 months. But the vaccine does offer, finally, a light at the end of the tunnel. These vaccines are safe, have been put through the same rigorous testing as all other vaccines, and millions of doctors, nurses, and medical workers have gotten their shots. So we want to make sure that everyone has access to the information that they need, and we're hopeful that brighter days are ahead for Massachusetts and everybody else across the Commonwealth and around the world. Please continue to do your part in the meantime to stop the spread. I didn't spend a lot of time talking about it today, but as you can tell from all our daily data, because of the hard work of everybody here in the Commonwealth, we are finally seeing some positive trends that have a bit of sustainability with respect to the second surge. That's all thanks to you. And with that, I'll turn it over to the Lieutenant Governor.
Good afternoon. Thank you, Governor. Today we are pleased to announce more vaccine sites will be available for all residents, and that our updated Phase 2 priority groups will begin vaccines for residents 75 and older on February 1st. Providing vaccines for all residents cannot happen fast enough, and we appreciate the public's patience as we first vaccinate Phase 1 to protect our healthcare system, our most vulnerable residents, and provide equity. In addition to providing more details on our progress with vaccines so far, I'd like to make an announcement about a new testing opportunity for early education and child care providers. First, our vaccine progress. As of yesterday, 651,875 vaccine doses have shipped to providers in Massachusetts, including first and second doses, and 224,250 doses are reported as shipped to pharmacies as part of the Federal Pharmacy Partnership Program, for a total of 876,125 doses. As of the end of the day yesterday, 448,892 doses of administered vaccine were reported to the MIIS. As of Thursday night, over 247,000 doses have been administered to healthcare workers. Over 86,000 doses have been administered in long-term care facilities through the Federal Pharmacy Partnership Program. Over 23,000 doses have been administered to first responders through vaccination clinics hosted by local boards of health. Over 3,000 doses have been administered in correctional facilities. In their first few days of operating, over 1,000 doses of vaccine were administered in commercial pharmacies. Relative to testing, as we continue to combat COVID-19, reliable child care is critical for parents and families across Massachusetts. Beginning in February, the Department of Early Education and Care will launch a pilot COVID-19 testing program for its providers, staff, and the families they serve. In partnership with the Massachusetts Early Childhood Funder Collaborative and Bay Coast Bank, 8 rotating drive-through sites throughout the Commonwealth will be stood up to offer PCR testing. The testing sites located in Athol, Braintree, Billerica, Dalton, Franklin, Plymouth, Sturbridge, and Westfield were selected based on distance from current state-sponsored Stop the Spread testing locations and concentration of child care providers. During the pilot program, EEC will continue to explore additional testing locations and will analyze data from the program to identify other possible locations and determine next steps. To provide further support for child care, EEC is also dedicating $8 million in state and federal funding to stand up a PPE fulfillment website for providers to order PPE supplies at no cost. 1 month's supply can be ordered, including gloves, masks, bleach, spray bottles, hand sanitizer, and wipes. More information on the pilot program, instructions on how to schedule a test, and guidance for PPE orders will be available online. We've made progress here in Massachusetts, but we still have more work to do. As more individuals are vaccinated through our thoughtful and equitable planned rollout, we get closer each day to a new normal in communities across our Commonwealth. Our administration continues to collaborate with public health experts, medical professionals, and local officials to ensure that we are delivering COVID-19 resources and support in the most efficient ways. We are grateful for the continued patience and shared commitment to eliminating this virus, and through ongoing partnership, we can turn the corner on COVID-19. Now I'd like to turn it over to Secretary Sudders.
Governor, Lieutenant Governor Michael, thank you for joining us today. Good afternoon, everyone. Our changes to the Phase 2 priority groups, as the Governor and Lieutenant Governor have indicated, protect vulnerable populations and ensure the equitable distribution of the COVID-19 vaccine. As you've heard, starting next Monday, individuals aged 75 or older are eligible to receive the vaccine. Later in February, individuals aged 65 or older and individuals with 2+ comorbidities will also be eligible to receive the vaccine, depending on the vaccine supply, of course, from the federal government. There are many people in Phase 1 who have waited to get the vaccine, and they remain eligible to book an appointment at one of our vaccine sites. Because we moved individuals aged 65 and older into Part 2 of Phase 2, we're no longer specifically calling out on the website public and private low-income and affordable senior housing. They obviously remain eligible. An update on congregate care facilities. Congregate care vaccinations have been steady over the last couple of weeks. Unlike some states, we have a strong, diverse, and dispersed network of community providers serving many of our most vulnerable residents. There are 94,000 individuals working or residing in some of these congregate care settings across 3,500 specific locations and 400 providers. These include group homes, residential treatment programs, individual and family homeless shelters, domestic violence shelters, veteran shelters, and special education residential education programs, assisted living residences, and rest homes, to name but some. These programs have different clinical capacity, partnerships, and serve residents with different needs, requiring the employment of a range of strategies in terms of vaccination plans. The clinics began on a rolling basis starting on January 11th. To date, 80% of our congregate care providers self-report that vaccination clinics have commenced at more than 850 distinct locations. There's a lot of logistical planning. We work actively and closely with each provider to ensure that each site can implement vaccination administration as quickly and safely as possible, utilizing the federal pharmacy program, supporting on-site vaccination administration, leveraging existing clinical and pharmacy partnerships, and encouraging the use of our mass vaccination sites. As we work to vaccinate Phase 1 priority groups, our commitment to preserving our healthcare capacity, protection of some of our most vulnerable residents, and equity are at the forefront of the planning. Communities of color and at-risk populations are prioritized to maximize life preservation and to prevent serious complications from COVID-related illnesses. The Commonwealth's COVID-19 vaccination distribution plan was developed based on recommendations from the CDC and our COVID-19 vaccine advisory group. As we continue to allocate constrained supply of vaccine, in addition to mass vaccination sites, our priority is to ensure that the lens of equity is reflected in the allocation and distribution. In addition to collaborating with the city in the opening of the Reggie Lewis Center, going forward, it is our expectation that retail pharmacy locations must prioritize Chelsea, Revere, Mattapan, Dorchester, Roxbury, and municipalities outside of Boston with communities disproportionately impacted by COVID. Our overall commitment is to create vaccination sites that achieve scale, geography, equity, and diversity across our state. Phase 1 has prioritized employees and other groups who have been historically marginalized or have significant representation from communities of color that other states did not prioritize, including individuals who are homeless, health aides, home health aides, personal care attendants, and the like. Michael Curry, president of the League of Community Health Centers, will have more to say about equity of the vaccine shortly. And finally, some changes we've made. Last week, we made 2 important adjustments in order to increase the rate of safely administered vaccines in the state. As the governor said, we have distributed 651,875 doses of COVID vaccine to providers in Massachusetts, including both first and second doses. It represents more than 98% of what we have received directly from the federal government. Another 224,250 doses have been allocated to the federal pharmacy program. Each Friday and Sunday, when the Department of Public Health receives the vaccine allocation from the federal government, the department pushes our weekly allocation out to the provider community. To date, our distribution has largely gone to hospital healthcare systems, with smaller amounts to local boards of health, corrections, congregate care, and the like. Last week, we made it crystal clear that providers have 10 days from the receipt of the vaccine to administration. All hospitals were contacted last week to review their existing inventory and their administration plans. We are actively monitoring their scheduled clinics and the vaccine utilization. This week, hospital systems did not receive additional vaccine inventory. They need to utilize what they have in hand. And if we must, we will redistribute these fragile vaccines to other providers. The second change involves the federal pharmacy program. The federal government required the allocation of 50% of our first doses in order to launch the program for skilled nursing homes and congregate care. These programs have been much slower to ramp than initially anticipated. As of January 19th, 300,000 doses had been allocated to the federal pharmacy program, and only 80,000 doses had been administered. Last week, after back and forth with the federal government, we received permission to pull back doses and halt further vaccine allocation into the federal program in order for the federal program to use what they have in hand. So, as of today, we have halted further allocation to the federal pharmacy program until the existing supply is well depleted. We have redirected 17,500 doses a week for the next several weeks from that pharmacy program, from the federal pharmacy program, to CVS and Walgreens retail pharmacy. and we pulled back 20,000 doses from the federal pharmacy program to distribute doses directly to Massachusetts providers. Let me be clear, CVS and Walgreens have been good partners during this process. We expect them to fully utilize their existing supply in the next few weeks, and at that point, we will then resume allocating vaccine to the federal program. In the coming weeks, as CVS and Walgreens work their way through this supply, and as hospitals work through their supply, our ratio of doses administered compared to doses distributed will improve. And with that, it's a privilege to turn the podium over to Michael Curry, who's the President and CEO of the Massachusetts League of Community Health Centers.
Thank you, Governor, Lieutenant Governor Polito, and my friend Secretary Sutters. I am Michael Curry, President and CEO of the Massachusetts League of Community Health Centers. Our 52 members serve on the front lines in our state's most vulnerable communities, providing primary care and preventive care to lower-income patients and communities of color across Massachusetts. I thought I'd start today with where I originally intended ending, which is to the hesitancy that exists in communities of color about this vaccine. I think of the many things that we'll talk about over the days and weeks and months ahead is that there is a reluctance in the communities where I was born and raised in Roxbury about this vaccine. And I want to urge people to trust the science, to get the facts, to not trust the misinformation that they get on social media and that they hear from, in many cases, their home countries, their home communities, and to know the facts about this vaccine. Because when it's their turn, when it's our turn, when it's my mother's turn as a 76-year-old woman with 2+ comorbidities, when it's her turn in line, I want her to trust the science and listen to her primary care provider. I've had the honor and privilege of serving on the Commonwealth's COVID-19 Vaccine Advisory Group and can say with great certainty that equity is and will continue to be front and center in the state's carefully considered rollout of the COVID-19 vaccine. We were very clear and quick to acknowledge that the virus has not affected everyone equally. We know that our Black and brown communities have higher rates of infections, hospitalizations, and deaths from the virus. Too often, up to 3 times higher rates in Black and indigenous communities of color across the country and here in Massachusetts. With that stark data in front of us, we understood that an equity lens needed to be applied at every stage of the rollout. As Secretary Sutters often says, in the first phase, we knew it was imperative to start with our healthcare workers for 2 reasons. We needed to ensure their continuing ability to manage this pandemic. And because many of those who work on the front line in healthcare roles as personal care attendants, medical assistants, and home health aides are also people of color. That is also the case for other populations prioritized in this phase, phase 1. Individuals experiencing homelessness and living in congregate care settings, including the incarcerated. I want to understate that. As Secretary Sutters pointed out, we did something different than much of the rest of the country. Our prisons, our jails are overpopulated with too many people of color. And that's an ongoing issue in this racial reckoning that we're trying to address, is the overrepresentation of Black and brown people in our prisons, but we know that they're at risk. And too far often our Black and brown and Latinx communities are being impacted, and we need to take that in consideration. In phase 2, we focus on seniors and individuals with 2 or more comorbidities, with additional allocation for those communities with higher prevalence of the disease and social vulnerability. We know from looking at the data that the cases of COVID-19 infections for Black and Latinx individuals are worsened by underlying conditions such as hypertension, diabetes, and asthma, all related to an historic lack of access to care and structural racism. For example, 42% of Black men and 43% of Black women suffer from hypertension, compared to 31% of white men and 27% of white women. For diagnosed diabetes, Hispanic men are at the highest rate at 14%, followed by Black women at 12%. 12% of Hispanic women develop diabetes. That number is 11% for black men. Whites have the lowest rate for developing diabetes across all groups. This pandemic has heightened our consciousness about the underlying disparities born out of these inequities, and I've described this as our national Katrina. In phase 2 and phase 3, when the vaccine becomes available to the public, there have been significant investments made to reach Black, Latinx, and many other immigrant populations who may be in need of more information to make empowered decisions about getting vaccinated. Campaigns by the Department of Public Health and my organization, the Massachusetts League of Community Health Centers, with messaging that addresses their questions and concerns around social media platforms, through virtual town halls and community events at churches, and socially distant settings that allow for listening and talking about people's fears, as well as their goals for health and safety and hopes about life post-pandemic. That will include using doctors who, as we know from the state and national polls and studies, are our most trusted source of information about the vaccine, and relying on a multitude of voices and languages to ensure that information is accessible for populations. Overlaying all of this is a commitment by the governor and the secretary to open up vaccination sites in Chelsea and East Boston and Revere, with the hope that our community health center member, East Boston Health Center, will be there and to serve those communities. Health centers historically have been primary vaccinators in the communities that they serve and have played a frontline role in responding to COVID-19. Health centers are meeting with our community partners and continuing to plan for this next phase of patient vaccinations in communities like Dorchester, Roxbury, Mattapan, and other hard-hit communities outside of Boston. Lastly, we encourage those who are concerned about quality and equity and access to continue asking the critical questions. And we have a responsibility, both as providers and government, to answer those questions and to adjust where we can to those needs and concerns as they're expressed. Lastly, I'll end where I started. As we roll out this vaccine to large populations, it is critically important that everyone lend their voice to the truth about this vaccine, the efficacy and safety. So we at the Mass League, the 52 community health centers serving over 1 million patients, want to partner with you in that rollout of this message that this is about saving lives. And we thank the governor, the lieutenant governor, the secretary for including us in this effort to get back to normal in the communities where we serve and across the country. So thank you.
Questions?
Governor, the Senate President yesterday criticized the rollout as confusing, that a lot of people don't understand how they can sign up even to get this done. Do you think the process is confusing?
I think in Massachusetts we made some decisions, and I think Michael spoke to this, to focus early on some hard-to-reach populations, which is different than what many other states did. And I think the reason we did that was we were concerned that many of these populations were not only hard to reach, they were vulnerable populations, and they were ones that we believed, as part of our overall strategy, we needed to make sure we got to first. And I do think the decision we made to focus primarily out of the gate on long-term care residents and staff, on hospital workers, on home health aides. Remember, home health aides are not only, as Michael said, in many cases, people of color, and PCAs are people of color, but they also serve, in many cases, especially home health aides, many seniors who are often people of color who have health issues that those home health aides are helping them deal with. So having those folks get vaccinated by definition will make things better and safer for the population that they serve and take care of. And I get the fact that by choosing a number of very targeted communities and populations that we felt we should start with, that would create a slower rollout and a slower ramp up than you would see where you just took big groups by age and said go. But I do believe at the end of the day we made the right decision out of the gate, and the fact that we're going to add literally dozens and dozens of sites that will bring our capacity, whether we have the vaccine or not, up to hundreds of thousands of people per week who can access and get vaccinated, should deal with many of the issues and the questions that people have raised. The one point I would make with respect to that is it's going to be important for people to go to the website, click on the site that's closest to you, and determine if in fact you're eligible, and if you are, make an appointment. But we are overbuilding here with respect to what we anticipate we're going to get from the feds by the time we get to the middle of February. And I certainly hope I'm wrong about that, and I hope that the feds give us the vaccine that we'll need to actually make sure that every single seat and every single appointment can get filled. But at this point in time, what I would say to anybody who's confused is go to the site, determine when you're eligible, find a site that's convenient for you, make an appointment.
The state has also been
the best practices. It seems like you've made some tweaks that Secretary Sanders was talking about, specifically with the federal pharmacy program. What was the issue there? Was some stuff kind of lagging, or just kind of sitting there and not getting into?
Well, the thing to remember about the federal pharmacy program is you had to have enough vaccine available to serve 50% of your population on the long-term care program. Some states have much smaller long-term care communities than others. We didn't have enough vaccine to serve the size of the population that would be represented by 50% until we got to the second week. The rollout itself, they're planning to make 3 trips, right? They've done 1. Are they in number 2 yet? They're just still working? So far, the take-up rate on residents has been pretty high, sort of 80% plus. The take-up rate on staff has been more like 50, and that's part of the issue.
I'm asking for other states that are using their best practices. I mean, some of the ones that have better administration rates, so to speak, based on some of the things you talked about, how they're doing it a little bit differently, but are using any of their, some of the states that have it better?
Well, some of the states made a decision to not participate in the federal program. They had much smaller long-term care communities than we did on a per capita basis, and certainly that decision gave them a lot more control about the rollout. But most of what I would describe as the larger states that have the greatest number of long-term care facilities on a per capita basis are participating in the federal program, and I've talked to a bunch of governors who have some of the same issues and concerns about the pace of that we have.
Governor, why doesn't the state have
check with the state of Connecticut? I mean, they seem to be doing so well, and I'm assuming that many of their priorities are similar to yours: nursing homes, healthcare workers. We've checked the CDC website. People are keeping score. Massachusetts lags the rest of the New England states and New York, but Connecticut seems to be a standout in terms of how well they're doing.
Connecticut, to the best of my knowledge, did not put in their initial priorities many of the vulnerable populations that we did, which we said would take longer because of the nature of getting to them. Mobility is a big deal. If you can't get to a site, which many of the populations that we chose to serve first can't do, you have to get to them. Secretary Sutters talked about the fact there's 850 locations involved in serving many of the people who are part of that congregate care community.
So
that's a lot of outreach and a lot of work.
As you look at your decision, there's nothing you do differently. You think that everything's been spot on?
I think, well, look, if I had a better understanding and more insight into a number of these issues, I might have thought a little differently about them. But let's all remember that we were making the decision, especially about health care workers and where we were going to put them in this puzzle at exactly the same time we came out of Thanksgiving, and our daily case count doubled, our percent of positive cases doubled, and our hospital admissions took off. And from our point of view, we looked at that and said, we have got to make sure that our healthcare system is going to be able to serve the people who are going to be dealing with COVID and continue to be able to serve the people who need to access the healthcare system but aren't dealing with COVID. And thankfully, we now appear, for now, to be on the other side of that surge. But that's what was taking place at the time we were making some of these decisions.
Governor, why doesn't the state have a central
Can I let the woman behind you go, Charmin?
Have a central registration website. Some other states have one giant site. You can go on now, put in your DOB and whatever. I know
First of
that
all,
there's
where's the
one
map?
site, but it leads to some others, so I just didn't know if there's any plans to have one central registration site.
We're going to have you'll be able to go on the website. You can go on the website, determine if you're eligible on the site, find a location that's providing vaccinations that's convenient to you, click on it, make an appointment.
No plans to streamline that, though.
How much more streamlined would you like it to be than that? That's pretty, look, I think that's, for most people, being able to determine if you are eligible, where the site closest to you might be, and how you can make an appointment on that site, all at the same time, should be, for most folks, a pretty easy way to make that happen.
Last night, the Department of Public Health told cities and towns that they're going to be capped on the amount of vaccines they're going to receive through the end of February. Some are expecting hundreds a week now, they're only getting maybe 100. Why this sudden limit on cities and towns?
Well, it depends upon which city and town you're talking about. In some cases, it has to do with the amount of vaccine they still have available, right? And in some cases, it has to do with the amount of vaccine we get from the feds.
But has there been a change in direction from the feds that prompted that? Are you planning to move more into the mass vaccination sites? Because the cities and towns are saying this is sort of a rough change from the understanding what they were.
Do you want to speak to this?
So the request we get, Matt, the request we got for this week was 2.5 times what we have for supply, one. And secondly, that's everything. That's everything. And what we are doing now is asking everyone, what do they have in hand? What do they have scheduled? And then if we can, we will do the delta of that. So if a town had scheduled for this week 500 appointments, let's say, and they had in hand 300, 350, then what we tried to do in doing the allocation was to give them the delta so that they would have 500. So this is, as we have said, we have a constrained supply from the feds. We clearly, mega sites are important for us because they are efficient. And so clearly having the mega sites are important to us. Retail pharmacy, lots of sites, wherever the map is. Lots of sites for people to be able to get to, and then distribution to local boards of health. But in all cases, we now are seeing what you have in hand, what's scheduled, and then if we can give you whatever the delta is.
Governor, I wonder if you had any, last time we talked to you regarding your communications with the Biden team, it was actually before the inauguration, and they had said you can really just expect to be getting the same amount of doses that you had been getting. Is there any sort of an update, especially given that in order to meet that administration's goal, you said we need 25% more doses. Is there any sort of an update on the number we're going to be getting here in Massachusetts?
The only update we have from the administration at this point is sort of an informal one, which is that they are currently working on what will be sort of their rollout plan going forward. But we haven't received specific guidance other than we should continue to expect for the next few weeks what we got the last few weeks, no less.
So the point, I guess the bottom line is you really just don't know that you're going to have enough doses to administer to all these people.
If we just continue to get what we've been getting and we do what we're planning to do over the next 2 weeks, as I said, we will have empty seats and open appointments that we won't be able to fill. Because our goal at this point is to go as hard as we can for the next 2 weeks in anticipation that we may have more. But if we don't, we will have empty seats and open appointments.
Governor Lucas, whom we know well, has said that she doesn't even know how much vaccine the federal government has. Things were such a mess under the previous administration. Do you know how much vaccine you have and where the bottlenecks are?
Well, I think part of my answer to your question, Jonathan, is what I said to Sharman, which is that's why we've only gotten sort of an informal sense from them about what we can expect going forward. I think Mary Lou talked about or the Lieutenant Governor talked about the fact that virtually all the vaccine that we have received as a Commonwealth has been distributed to either the long-term care community through the pharmacy program or to providers, both community providers, hospitals, congregate care settings, and others, to begin the process of either first dosing people or second dosing people. I mean, one of the things everybody should remember here is that people keep score on this as if this is a one-dose vaccine. It's not. I mean, everybody who gets a first dose needs to get a second dose. And one of the reasons I have said to you many times at these press conferences is the thing I would like the most is more visibility into what's coming next, is so that we can make appropriate decisions with high degrees of confidence that the vaccine we put out the door for first doses will work and that we won't need them for second doses at some point a couple of weeks later. That's in some ways one of the greatest challenges I think we all have on this, which is how much of this can you actually first dose with people? You can make estimates, which everybody does, and we've been careful about that. But you can't literally say, as you look down the road, especially when you have the new head of the CDC saying, not exactly sure, you got to be careful about just first dosing and worrying about whether or not worrying about whether or not you're going to have second doses when you need them 21 and 28 days later.
So you shipped 98%, less than 50% has been administered. So hospitals are holding it, nursing homes are holding it, and they're not getting shots. Can you pull it back? Can you send it to someone?
Well, that's what. Why don't you speak to that?
So instead of just allocating out, the adjustments we've made is literally hospital by hospital, understanding what they had in hand and then what was being planned for the next week. And we've made it very clear. We put out the guidance last week that you have 10 days from the time you receive to administer. And if you don't, then we will redistribute. Now, the one thing I'd say about redistributing is, right, it's an mRNA vaccine. So it's a fragile vaccine, right, that requires certain cold storage and the like. So these are not vaccines you just sort of pick up and, walk across town. So what we want to do is to make sure that people are really conservatively planning their allocations and that we understand what their schedules are. And then we're coming now back to monitor this week what they said, what they've scheduled. And yes, we have said we will redistribute if we need to. On the federal pharmacy program, we finally were able to get the federal government to allow us to, one, halt any more deposits into the federal pharmacy program, and then literally redirect 20,000 of the doses from the federal pharmacy program into retail pharmacy. And that's this week, and that is where you see some of the proliferation of pharmacy sites, is that 20,000 has been redirected into those sites. So we're being very now, well, we've always been monitoring this, but we really want to understand what you have in hand, and then what's scheduled, and then we come back to check, and then you may get a next allocation. And this week in the hospital systems, there is no new allocation because they have plenty of doses in hand for their first and second doses.
Secretary, the one I was trying to ask earlier was,
yeah,
why did that best practice change? Do we not have information?
So again, we're like, 5 weeks into vaccination? And in the beginning, because you don't get from the federal government, the governor and I were talking about this earlier, we get like an allocation. And so when we first started to order vaccines for hospitals, say the first allocation from Hospital X was for, say, 10,000, I'm just making up these numbers, right, 10,000. So we put that allocation in. And if it was Moderna or Pfizer, then 3 weeks later, we put in another 10,000 doses to make sure they had the second dose amount. And what clearly hospitals and everyone over anticipated what the uptick was for vaccines. I mean, I think you heard Michael Curry talk a little bit about that. We've seen that in the long-term care facilities where like about 50% of the staff have accepted vaccines. It's about 80, a little bit over 80 for residents. So I think in the beginning, people were enthusiastic about vaccines, and anticipated an amount that turned out not to match what the acceptance rate was. And so we've now gone back with folks to readjust it down significantly. And that is all part of like the maturation of the vaccine program. And again, we look forward, and with constrained supplies, we need to get doses out, distributed, and into people's arms as quickly as possible.
Does that tell you that there's an amount, a good amount of people in phase 1 who didn't want?
Well, again, and it's not to overemphasize the long-term care industry, but in the long-term care industry, of which we have about 80,000 individuals who are either served or residents or workers, it's 52% of staff have currently, so at this time, because we're still rolling out, 52% of staff, and it's about 84% of the residents. So we continue to work, and on the hospital side, I just don't have the hospital data in front of me in terms of the acceptance rate. But we clearly need to keep working with people.
Can you clarify, will the state wait until everybody 75 and above is vaccinated, and then we'll open up to 65? What sort of percentage are you looking at before you go to that 65? And then do all the 65 plus get done before?
No, thank you for that. It's not a linear process. This is obviously, we're trying to build, as the governor said, build the infrastructure and the capacity. So by February 15th, right, we'll have staffed capacity for vaccinations, about 305,000 doses a week. So we're trying to build the capacity, right? And then see what we have available, and then just continue to start to open up. And it doesn't mean that folks in phase 1, like the COVID-facing healthcare workers, can't continue to be vaccinated, but we want to continue to move the progress. So it's not linear at all. It is trying to literally determine how safely we can expand eligibility and not have what has happened to some other states, right? Where you're eligible, good luck trying to find a vaccine appointment.
And how can folks people over 75, who might not be internet savvy, might not be able to get up, how do they book their?
Right, so at 1 o'clock today, I think it is, this afternoon, the wonderful Executive Office of Elder Affairs is putting out a massive communication to their network of councils on aging, their community groups and the like, talking through 75 plus eligible as of next Monday, and reaching out to individuals who are over 75 in their communities, ask if they need help to get them vaccinated. That's one thing we're doing, obviously. So we're just trying to get the information out. There are certainly some who will go online and do it, but we're really putting the message out to community groups who are well connected to this to help folks.
I just wanted to ask you a data question. Every day sometimes we get numbers from the governor on the supply and then the doses administered, and then we get a report from the Department of Public Health, and then we get a report from the CDC, and the numbers don't line up, and we're trying to figure out which are accurate, and we're getting messages from viewers saying that they're confused.
I would never dispute that answer. So the governors and the DPH the governor pulls from the DPH daily data. The issue between CDC and the state is literally just a timing. What time the CDC pulls the data versus what time we pull the data to report. It is literally just a timing issue.
Secretary, when you move to the phase of cohort,
I'm sorry?
When you move to the phase of the cohort mortality, the second phase is in phase 2.
Right.
Or I guess it'd be the third phase, we have comorbidity.
No, it's so individuals 65 and over, or individuals with 2 comorbidities. Sorry.
The question is, are you guys going to ask people to prove that they have comorbidities?
It's a self-attestation.
It's a what?
A self-attestation. When you go online and find where you want to get vaccinated, there is a self-attestation that you also fill out. It's up now.
Is it fair to call that an honor system then, to determine if they fall in or are eligible to receive it?
Just like it's an honor system now if you're a home health aide. I mean, this is based on a self-attestation process.
Thanks, everybody.
Can I speak to the CDC? Can I just speak to the difference between the CDC data and other people's data? I mean, honestly, since this process began, there was the COVID tracking project, Johns Hopkins, COVID exit strategy, COVID Act Now. Is there any other ones? Are those? There were a lot of websites all around the country that were aggregating data, mostly from the CDC, and I would look at it all the time because I was doing the same thing you all do, which is compare me to other states, and I would constantly be calling Mary Lou and saying, this data on COVID Act Now, this data on Johns Hopkins, this data on COVID exit strategy, this data on the COVID tracking project, it's not the same as the data that I get from you, and frankly, it's making me a little cranky. And the big lesson I took from that is in the translation from what the state reports either to me or to the federal government and what eventually lands in the CDC reports, which is where most of the national scoreboards are being kept, they're just different. And some of it has to do with timing. I think some of it also has to do with definitions, and I think some of it has to do with what we might call an A in our database. They call an A squared or something like that. And I've just kind of accepted it. Like I look at the data on the COVID Act Now site, and if I look at the COVID Act Now site, which is mostly CDC data today, I can promise you that I will find stuff on that data site that I will look at and say, that's not consistent with my view of the world. Now, is it like hugely different? No. Is it different enough to get my attention? Yes. Is it relatively different across lots of other states so that for comparative purposes it still serves a useful purpose over time? Absolutely. I mean, so when I'm looking at hospitalization data, when I'm looking at case counts per 100,000, when I'm looking at a lot of the other elements that are on those sites, for my purposes, they are helpful in helping me create some degree of relativity with how I'm doing relative to others. And I'm competitive enough to care about that. And if I see something on it, I'll call somebody in another state and say, help me understand why your numbers are this and my numbers are that. And that's why I ended up calling a lot of governors about this nursing home thing. Because I was looking at our data and I was looking at their data and seeing they were having some of the same issues with getting shots in arms that we were, and discovered that many of them had exactly the same issue we had. So I think those sites are incredibly useful, and I think the CDC data is incredibly useful for the same reason, as a relative measure. But if you're looking for precision across all those data, there are 100 data elements that we send every week to the CDC. 200 now. It's just, you're not going to get boom, boom, boom. What you will get is a pretty decent sense about relative position. And honestly, one of the things that's been particularly interesting to me, and I'm carrying on here, is when I line up hospitalizations per 100,000, which to me, you can't fake hospitalizations. The number of people you have in the hospital per 100,000 with COVID and the number of people you have in the ICU, that's a pretty solid number, right? When I line that number up with cases per 100,000 or positive test rates, you can learn a lot about who's testing and who's sort of testing. Because there are plenty of places in the United States right now that have a lot more people in the hospital that are COVID patients on a per capita basis than we do, who appear to have positive test rates and cases per 100,000 that are dramatically lower than ours. Now that says to me that I'm doing a lot more testing in Massachusetts than they are. So I wish I could give you a better answer on how this lines up, but it's just always going to be a little messy at the end of the day.
What about reaction to people going to other states? We've been hearing about, particularly New Hampshire, people have property up there. I spoke with a doctor who she should be in phase 1, she got impatient, she went to New Hampshire and got a shot very quickly. Any thoughts about that?
You can't actually.
You're not supposed to do that, but
I mean, she's licensed to practice in New Hampshire.
No, you actually,
you didn't tell me that part. She's licensed to practice in New Hampshire. That's a different answer.
yeah,
In both states.
Yeah.
that's,
Yeah, she's licensed to practice in both states. That's fine.
Governor, your administration had said at the start of the rollout that you plan to put 20% of doses aside for highly vulnerable cities and towns. Have you guys determined which towns and cities actually are? Do you think you're still going to be able to do this given the continuous constraints on supply?
That's more of your question than my question.
What was the end of it, Matt?
If we are going to dramatically expand our capacity to
Oh,
deliver,
yeah.
what does that mean with respect to the 20%?
right. So the 20% is effective in phase 2, like when we go into phase 2. And as you heard when I said, we're prioritizing like pharmacies and I listed off a bunch of, Mattapan, Dorchester, Revere, Chelsea, and there's a bunch of other municipalities. So one of the things that we will do is we will start to use the data that we have to see what the penetration, the administration is of doses, and see if where we need to make adjustments and put in more doses into those communities in order to achieve that 20%. So that's sort of like a layer on top of, we get the sites up, right? And then you start to look at where you need to now put in more doses and the like. And it sort of goes back to the question you asked earlier when you said, so I'm assuming you've talked to some local boards of health who've gotten their allocation and it's not what they had been hoping for and had asked for. And so when we get the allocation request coming in, when we get into phase 2, we will obviously be making adjustments on ensuring that those communities receive the 20% and also that they're being used. I mean, that is also one of the things that we clearly need to do is ensure allocations and what's in hand and what's being used. So as we continue to make adjustments, but we are committed to that 20%.
Will you have a formal list of towns and cities that qualify?
We have a map. We have a map that we have that's that shows which communities have been most disproportionately impacted by COVID. Yeah.
Thanks, everybody.
Thanks, folks.